Yeah.
No, well, we had a choice, like with Amanda, they pushed for the G-tube. We had the NG tube, so when she came home, I used to have to pass the NG tube down her nose, and it was horrendous. And
we almost went home with that too.
I was in tears at 2 in the morning with the doctor, and one day he said, pull it. He said, pull the tube, and let's see how she does. And that's when we started adding cornstarch to the formula. And then when my son was born, he was at a different NICU, because he was only 3 weeks when he was born, so I had the preeclampsia too. So they took him 10 weeks early. And I told them from the beginning, you will not place a tube in my son's nose. I said, if he doesn't respond for the amount of calories you want, then you need to up his IV. And I put my foot down, and they worked with him, and he took a bottle like a champ. And it made a world of difference with just being able to feed the baby bottle and keep the blood sugar stable. My mother-in-law would be hiding. We had security from Sears come one time. She was hiding in the clothes rack. We used to have to rock her to sleep and kind of sneak the bottle in her mouth for her to drink the bottle because she would throw up. She had reflux. And rock her to sleep, put her kid in the bottle, let her sleep for 5 minutes, and then wake her back up because she had such an aversion to the bottle. And they said, well, we'll place a G-tube. And I said, no, you won't. I said, I don't care if she has to stay on an IV with glucose. You're not going to place a G-tube. It's not going to happen. Yeah. So I think the feedings with the tubes, that's something that they need to work on. You know? And it's a learning process for them, and that's the easiest for them to control the situation, but it's not easier for you.
I had a nurse at Cook's tell me that they felt like that's why it was done so frequently.
It's easy.
Because it was convenient.
It's easy for the nurses. They just dump it and go on their way.
Yeah.
Well, there's so many times that I can tell you where some things you just had to go by your instinct.
Well, and you got to fight too.
Before I moved into the room with her, I got to the hospital. I was staying at the Ronald McDonald House in Philadelphia. I went by myself with her. So I was staying there, and I got there that morning, and she wasn't responsible. She had a glucagon kit taped to the back of her bed to give her an immediate notice if her blood sugar started dropping. That's why it was there. But the nurses, when I said, look, her blood sugar's dropping.
This is a chop?
Yeah, this was a chop. This was up on the endocrinology wing. But it's not as monitored when the kids are in the rooms by themselves. You know, but she was in there with her other little roommate. And I noticed something was wrong. Had them check her blood sugar. Yes, it was low. I said, there's her kit. Give it to her now. It was 36. And they would not give it to her because they didn't have the doctor's order on it.
Yeah.
So I grabbed her IV, I grabbed her bed, we hit the elevator. We were going up to Nikki to get the shot. And we got to the elevator, they couldn't stop me. We got to the elevator, the doctor called in from the return of the page saying, give it to her. They gave it to her right then and there in the elevator. I was like, I said no. And that's what prompted me with it.
What are the chances of removing that G-tube? Like later on, like what's the? If they haven't had one, what do they do?
For us, we've been told that when she is old enough to understand that you have to eat, it's not optional.
She doesn't understand you have to eat. It's not optional. She's 14.
It's
true though. It's true though. It's true.
I don't hate it, but there have been times where she has been unresponsive. She would not, wouldn't or couldn't eat anything, and I've been able to get her sugar out immediately.
We've always done IVs, dextrose IVs. Yeah.
But that was put in for her because her PDA didn't close, like over her valves, and she had a lot of respiratory problems. So to get her to eat on level, so that was why we got it originally.
But for a basic feeding problem, where you have that place, what are the chances of you being able to say, we want to remove it?
And like you were saying, someone comes and works with him. Like we have someone from East that's been working with her since she was 2 months old, and they have made a tremendous difference. Like she's eaten nothing by mouth for the longest time, and now she eats everything by mouth during the day.
So she just uses the G-tube at night.
And for medicine.
And for medicine. Yeah, I mean, we were told that they don't know how long that he'll have the G-tube, you know, until he starts eating on his own.
Is he ever going to start eating on his own if he always has to do? And I think
Yeah.
it's like that circle, you keep running and back and forth.
Because he doesn't really ever feel very hungry.
Sure. The D-tube.
And I know for Caroline, like they found that her stomach empties slowly, so it's like she's full and her sugar's low, and what do you want me to do? Like there's nowhere to put anything.
Yeah. I didn't know that there was an option to go home with an IV or a dextrose IV. That was never even an option for what they told us.
It's not usually, well, we'd have to take them in for it, and it's not an option unless you
have to, a lot of them are an option unless you're at.
you have to
You have
demand
to
it.
know. And
So did you go home? Did he have it at home, or he would actually go to like the hospital or the doctor to get
Go to
it?
the hospital, but our Colin's case is a little different, and we unfortunately didn't catch it. He has a specific mutation that kind of, like he'll get a loss of heterozygosity, which he has 2 strands. My husband gave him the bad strands, and
Okay.
his
Generally doesn't
occasionally,
change.
I know, and his like occasionally will knock one of mine out, so it's focal yet diffuse in a way, because like he'll have little focal points that just suddenly appear. So his case, you know, looking back, I think around 5 months, like hindsight, is when things started. He started getting ill, and he just had this look about him, almost like he was just constantly tired, and started passing out, having seizures. But I would take him to the hospital or to the doctor, and they'd be like, "He's fine. What are you talking about?" I'd go back, and it was a repeat pattern, and around a year is when he was eventually diagnosed. And so I think for me it's easier looking back, because then, you know, at a year old, it's less of a, I think it's easier to G-tube a baby than it is to G-tube
Make a
a,
baby, yeah.
you've seen him, he was pretty much like this willful at age 1. But no, that is the protocol for him, is when his sugars get lower, he has a stomach illness, we go right away, and they hook him up, and we do it, catch it, before it gets bad. It's a 1-night hospital stay versus a 2-week hospital stay. But
So have y'all found whenever your children get sick that their blood sugars run low?
But they can also have
It depends. Because see, he hasn't really been sick that we know of. We think when he was in the hospital he had a little cold, but he hasn't really been sick. So I just don't know what to expect for the future.
Like vomiting, diarrhea, anything stomach related where they're trying to keep anything down is when they usually run low. But we found that colds tend to run them high. She tends to run higher with colds, where I would think that, you know, her body would be, you know, just kind of tired out. It's not. She runs high. You know, higher, well, never been high. She's never been over 140 in her life, but, you know, higher than 60. You know, we see 60s compared to, you know, 130.
Yeah.
he's sensitive to food. If he eats something sweet, he'll hit 300 for 20 minutes, and then he'll go down fast. So
I'm sure having the Dexcom is going to help us a lot whenever he starts to eat food. So we'll know, okay, this is affecting him this way, or this is affecting him that way.
Well, my son did he had a 6th grade, they have to do science fairs, and we actually did this experiment on him, and we called it My Funny Pancreas. So what we did is, over a 4-week period, we did a test on different foods on his body, and as long as his blood sugar was around 85 in the morning, we did one day, we corrected over a 2-hour period. The first time we gave him a can of Coke, and over those 2 hours, every 30 minutes, we checked his blood sugar, and we write it down to see where his blood sugar went, his peak, and how fast he dropped. And then we did all protein, we did a mix, and we did all carbs. To see, so the soda was simple sugar. We did simple sugar, all carbs, a mix, and all protein, and then we charted them, and we saw where those numbers went. And it was so interesting to see how his body used his blood sugar over that time. And and we actually found that the can of soda was the worst for him because it shot up like 176, but within 15 minutes, you know, he dropped down to 90. He actually went lower than he started. And the protein didn't really do much for him. It kept him on the lower side, but it kept him more stable. But again, it didn't give him any kind of boost. And we found for him was the balance: more, you know, higher carbs, less protein, and actually all the carbs, the total carb, the pasta meal, made him drop the lowest because it just gave him a rush and gave him nothing to kind of balance it out. But it was an interesting experiment on him, and the teachers were kind of, they thought it was pretty cool. They'd never seen, you know, they're used to seeing, you know, what a plant does, you know, with sunlight and no sunlight. You know?
Yeah, and with the Dexcom, what's really cool is we can actually like upload it to a computer and see charts and graphs. And because sometimes I wonder if adding the polyglucose to my breast milk makes him, you know, shoot up faster and then drop faster. Because it's almost like sugar.
Yeah, is that
It's what
It's a derivative.
Studies on that to see how he does I looked into
we haven't.
because
We use polyglucose, but it's a derivative of corn. So that's because I asked that too, right?
It's a derivative of corn.
Corn, so it holds longer than like regular.
So it's kind of like doing cornstarch.
right.
To do cornstarch
Yeah.
for college, yeah, he drinks it at night.
Yeah, and the doctor told us as he gets old, when he gets a little older, that he can do the cornstarch. I guess little baby, she said cornstarch is not really good for their tummies. But so as he gets older, we'll probably try the cornstarch.
We said Pediasure.
Pediasure.
Well, he didn't have,
Yeah.
it didn't,
Pediasure, that has kept him stable, even more stable. They have a Pediasure.
yeah.
And that, he said, we've noticed.
So he just drinks it before he goes to bed.
They tried, before we got transferred, they tried everything. They had short I treated that injection, that isoxide, and
I've seen that.
and he still was not stable. So, with early birth, and I said, well, number one, it's coming out because obviously something is different. And that's when they went to change with the chop because obviously it's not what
So
he had high blood movement on diazoxide because he's on like extreme. He's on the highest weight count. He has his age and weight he has been at.
Yeah.
If he outgrows it, literally by an ounce, he starts seeing it crash. So we have to always tweak his meds. Like he's on right now he's on 3 mLs twice a day. And that's the max he can take. Doctors family still, we've done so many tests, and they still don't know why he needs such a high dose. They serum tested, he's metabolizing every single bit of it.
Now, see, River's on a very high dose of diazoxide, and we do adjust it with his weight gain. But since he's been home from the hospital and as he's gained weight, we have not had to adjust his meds in like 2 months. So that's a hope, and he takes it 3 times a day. So there's hopes that he'll outgrow it.